Hi everybody, this is Dr. Jenkins, and this is going to be the video for Chapter 7, which is the skeleton. So I just want to make sure that everybody's on the same page. For lab is when you're going to have to label the bone specifically, right? In lab is when you're going to label humerus, greater tubercle, etc. Here for lecture, we're going to be adding just a couple of functions. So for your lecture exam, there won't be any labeling, but for your lecture exam, we're going to add in some of the functions. And as always, I'm going to let you know exactly what you need to know. All right, so make sure that you review the axial versus appendicular skeleton. Axial, skull, rib cage, vertebral column. Appendicular, arms and legs. But I do want to point out the pelvis and the shoulder girdle, in other words, scapula and clavicle, are part of the appendicular. So that is one that's sometimes confused, but the pelvis, scapula, and clavicle are considered part of the appendicular. Good. Make sure you review. There are different types of bones. The most common bone is the long bone. So almost all the bones that we've talked about so far are long. The long bone is what we talked about in terms of structure, the diaphysis, the epiphysis, osteon, all that. So femur is an example of a long bone. Femur, humerus, radius, ulna. Technically, a long bone is one that is longer than it is wide. There are some other types of bones, and they're really typed by shape. Be able to give an example of each. A short bone example is a carpal. It's short. A flat bone would be the sternum, and an irregular bone example is the vertebra. Pretty straightforward, right? Now, you don't need to know these definitions. You don't need to know them. Ooh, that's gotta hurt, right? Ah! Sometimes people learn some of these because it helps them memorize the things for lab, but you don't need to know them for lecture. So we're going to go past those. So let's go through what you need to know for the axial skeleton. For the axial skeleton, you're going to have to be able to label for lab. These are excellent pictures if you want to use these to help you study as well. But remember, these have more than you need to know. But what I want to do now is I want to add in function. One function I want to add in is the foramen magnum. That is the opening in the occipital bone that the spinal cord passes through. So now we're adding function. Opening where spinal cord passes. Remember, foramen means hole. Magnum means big. So it's the big hole in the bottom. Excuse me, I'm having some allergies, so I apologize. The rest here you don't need to know for lecture. I know some of them are in red, but you only need to know what I'm going through. This is extra. This is extra, will not be on your test. If you're wondering, as an aside, there are certain things you can look for that would indicate a skull fracture. If you have any leakage of fluid from the ear or nose, and it's kind of honey colored, it's called halo sign because of that honey color. It can give an illusion, or it can give like that halo effect because of the color. But when you see that color fluid, you have to worry because that would be indicative of cerebrospinal fluid. Battle sign is when there's ecchymosis, that is discoloration behind the ear. Again, this is not going to be on your test. This is just extra. Ecchymosis is the fancy word for discoloration. You could have a skull fracture somewhere else in the skull, but because of gravity, the fluid can accumulate behind the ear, so you don't want to see that. And everyone probably is familiar with what raccoon eyes are, double black eye. That would also be indicative of a skull fracture. So not on the test, just extra. Make sure that you know the sutures. This will be a review from lab. Now we'll talk briefly about the fontanelles. We didn't talk about this in lab, we skipped it, but for lecture, I do want to talk about it. The fontanelles are the soft spots. The fontanelles are the soft spots located between the skull bones at birth. And from the textbook, it tells me that the skull bones fuse at around 18 to 24 months. So when the skull bones fuse, that's when there would no longer be any soft spots. We have some lovely pictures. So the fontanelles are the soft spots that are present before the skull bones fuse permanently. You don't need to know the names of them, just know what a fontanelle is. And of course, the reason is because we want to have a little bit of space for flexibility to make the skull more easily fit through the birth canal during childbirth. But also, the skull and the brain are going to continue to grow, so it allows for growth. But of course, you know, this means that you need to be careful when holding or dealing with a baby, because these soft spots are soft and therefore could be more prone to injury. All right, so continuing with our discussion of function, you already know the sphenoid for lecture. Look at all these, or for lab, excuse me. Look at all these things. Oh my God. Hopefully you see that I'm asking you much fewer than I could ask you. One of the things that was on the sella turcica that we talked about in lab, in the sphenoid, is the sella turcica. The sella turcica is that depression up top. Yeah, right here. It's that depression up top. Now we're adding function. The function of the sella turcica is to hold the pituitary gland. Hold the pituitary gland. It's a protective thing for the pituitary gland. Holds pituitary gland. That little depression is a nice, safe depression for the pituitary gland. On this next lecture exam, these questions are going to be very straightforward. It could be a question like, what is the function of the sella turcica? And you would pick the one that says, holds pituitary gland. We talked about the ethmoid in lab. That is the big walnut-shaped bone behind the nose. One structure we talked about on the ethmoid is the crista galli. So here we're going to add the function. I did mention it in lab, but let's just make sure that we cover it. The crista galli is the attachment for the covering of the brain. We haven't gotten there yet in this lecture, but the covering of the brain is called the dura mater. But that crista galli is a beautiful attachment site for the dura mater. Attachment site for the covering of the brain. Make sure you review this for lab, but you already will. Nothing here to add for lecture, but these are nice pictures. Here's a nice view of the foramen magnum. We talked about that. The opening in the occipital bone for the spinal cord. Nice pictures to study from. Here's also a nice frontal view. Some great pictures. Okay, this is extra. Okay. As you can see, I'm only adding a little bit, right? I know you have a lot to know otherwise, so I'm just trying to add a little bit. Make sure that you can define nasal cavity. Now, nasal cavity and sinuses, for some reason, they can be confused. So I just want to make sure that you're able to define each of these. The nasal cavity would be the passageway where air passes through. I like the word passageway. Passageway that air passes through. When we breathe in air, it passes through a nasal cavity. Actually, I have that drawn incorrectly. Let me be accurate. Thank you for bearing with me, like this. So the nasal cavity would be the passageway that air passes through. And it's made up of the walls of the nasal cavity are made up of multiple bones. The nasal bone, part of the ethmoid, the palatine, the vomer. You don't need to know what bones make it up, but just know that the nasal cavity would be the passageway that air passes through. And of course, that passageway is lined with bone. On the other hand, a sinus is an air-filled chamber in a bone. A sinus is an air-filled chamber, or I'm going to show you a better picture in a moment. Sometimes people like better hollow area in bone. So whether you want to call it an air-filled chamber or a hollow area. Okay, let me come back to this picture. So now we're still talking about the sinuses. Maybe I'll use a different color just to make sure it's clear. What color should I use? Let's use here. So now we're talking about sinuses. A sinus is a hollow area. So right here, part of the frontal bone is hollow. That would be the frontal sinus. You can see it here. See here how a part of the bone is hollow? That is a sinus. Let me go back to some other pictures because they show it pretty well. Here, what a beautiful picture. So look right here. Instead of the frontal bone being solid bone or solid, whether it's spongy or compact, instead of it being hollow, there's a part of it that is hollowed out. So that's what a sinus is. It's a little hollow area. So make sure you can define these differently. The nasal cavity is the passageway that air takes coming in. The bones that make up the passageway that air takes. But a sinus is a hollow piece. They try and show you in this picture as well. And the reason we have these sinuses is because it lightens the skull. We don't want our skull to be very heavy because we have to rest a big skull on a tiny little occipital condyle on one little vertebra. So it lightens the skull. And it also secretes mucus, which can help with filtration. So here we can also see the nasal cavity. Here's the nasal cavity. We breathe air in. So there are these sinuses that line the nasal cavity. They can secrete mucus to help filter incoming air. If you've heard of a sinus infection, that would be when there's inflammation and or infection in a sinus. Because there's so much filtration going on, the sinuses are going to be releasing more mucus in an attempt to combat whatever bad thing is coming in. So lightens the skull, secretes mucus. Hollow areas. Excellent. So make sure you review. We talked about the hyoid. Now I want to make sure you can define for lecture sesamoid bone. A sesamoid bone is a free-floating bone, meaning it doesn't articulate with another bone. There's only a couple in the body. The hyoid is one. The hyoid doesn't touch another bone, free-floating. Now, of course, the hyoid is encased in other connective tissues like ligaments and tendons, but not bone. The other example of a hyoid bone is the patella. It's pretty rare, right? Out of all of our bones, there's only a couple that are free-floating. As an aside, this will not be on the test, we do have 2 small sesamoid bones under the ball of your big toe. If you've heard of, sometimes runners can get sesamoiditis. That's just because additionally we have 2 more small, almost like little rocks. two little sesamoid bones under your big toe, but you don't need to know those. All right, let's review the vertebral column. So you already are going to know the segments and how many bones are in each segment. But what I want to do for lecture here is I want to add in curvatures. When you look at the vertebral column from the side, a lateral view, of course you see there's curvatures. Now, if you're looking anteriorly, there should be no curvature. From the front or from the direct back, there's no curvature. If it does, that's called scoliosis. But from the side, we should see curvatures. The function is it's better weight distribution. By having some curvatures, it widens the area with which we can distribute the body weight that the vertebral column is supporting. We can name these. So let's do that. This is like a backward C. That is called a lordotic curve. A lordotic curve, so what you need to know is a lordotic curve occurs in the cervical and lumbar. If you ever see a capital letter with an apostrophe, that's just shorthand. So we see lordotic, that shape curve in the cervical and lumbar. The opposite is like a C shape, and we see that in the thoracic and the sacral. And that is called a kyphotic curvature. So you need to know we have a lordotic natural curvature in cervical and lumbar, lordotic, cervical and lumbar, kyphotic in thoracic and sacral. Good. Now, they can be exaggerated. So if they are exaggerated, it becomes lordosis or kyphosis. So a normal curvature, lordotic or kyphotic, that's normal. But if it's exaggerated, lordosis, that suffix sis means exaggerated or pathological. Good. Now I've got a lot of pictures in here, and most of this stuff you don't need to know. Sometimes I just like to include pictures so you can see how things are together. We do have a bunch of ligaments in and around each of the vertebrae, and that helps to hold them together. I think it's pretty cool. So you can read about those if you like, but it will not be on your test. Please make sure you review some of the things we talked about in lab, such as the vertebral foramen. That's on your lab list. Now we're adding function. It's the opening in the center of each vertebra where the spinal cord passes. You can call it vertebral foramen or vertebral foramina, either one. Same thing, hole in the middle. Remember, foramen means hole. Please review the intervertebral foramen is the opening formed on the side. So once we see the vertebrae stacked together, there are openings on the side called intervertebral foramen or foramina. This is where spinal nerves come out. Sciatic, for example, is a good example for you to remember. Lower in the lumbar region, the sciatic nerve comes out of one of the intervertebral foramen. So these are the holes on the side formed by stacking vertebra. Whereas the vertebral foramen, not intervertebral, the vertebral foramen is the hole in the middle for the spinal cord. I would also like you to review the superior and inferior articular processes. I'm talking about this because this is how the vertebra stack together. We haven't really talked about that yet. Obviously, these vertebrae stack on top of each other. The surfaces that allow for that are the superior and inferior articular processes. Here's one right here. Here's one. What the articular processes are, sometimes they're called facets. They're basically flat surfaces. They're really just flat surfaces. If I remove my drawing so you can see it again, an articular process is a flat surface. But here we can zoom in. The flat surface of one vertebra will connect with the flat surface of another. If we wanted to be specific, we certainly could. We could say that the inferior articular process of this vertebra connects with the superior articular process of the other. So the black here is the inferior articular process. We're talking about this vertebra, right? The black one is the inferior articular process, touches and stacks together with the superior green articular process of the one below it. So this is how they stack together. All right, make sure you review the C1 is the axis, C1 is the atlas, C2 is the axis. C2 has the dens, which is the mini penis. The dens sticks up into the atlas and allows us to shake our head yes and no. Particularly that allows us to say no. We wouldn't be able to move our neck no in that way without this arrangement. This is a review. I talked about it in lab. Here's a nice way to see how everything fits together so we can label it. So here is C1 atlas. Here is C2 axis. We can see C2 and we have the mini penis coming up into the atlas. There is a ligament there, but you don't need to know that. But some good pictures for you here. Don't forget to review the 3 different shapes. So we talked about the cervical. Cervical are the smallest of the vertebrae. Something else that was unique is they have a hole in the side. That allows for the protection for the cerebral arteries. Thoracic has a really pointy spinous process. I said it kind of reminds me of an elephant trunk or a giraffe neck. And then lumbar has the biggest, fattest body for weight bearing. So make sure you review that functionally. Again, excuse me for my nose. Okay, I got some pictures on there. All right. Now, this is something new. Please make sure that you review the structure of the intervertebral discs. So now we're going to be talking about the structure of the discs that sit in between the bodies of the vertebrae, right? If I go back, all these pictures show you, let me go back, I'm sorry, here. All right, it's too far back. Well, you can see it here. Now we're going to be looking at the discs in between the bodies of the vertebra. Now, we already talked about one part of it, the fibrocartilage, but let's be more specific. So each intervertebral disc has 2 parts. There's a central part called the nucleus pulposus. Nucleus means center, so it makes sense. Nucleus pulposus. This is more gelatinous. And it's really for some elasticity. So the center part of each intervertebral disc is the nucleus pulposus. The outer rings are called the annulus fibrosus. Annulus fibrosus, outer rings. And these are what's made up of fibrocartilage. This is really what gives us strength. We know fibrocartilage is the thickest, toughest cartilage. So we use that to give us strength with a little bit of flexibility in the middle. The annulus fibrosus is many, many bands of fibrocartilage. Again, excuse me again. Now you can see here at the top, I've got a picture of a s'more. And I do that because I think it can be a useful way to think about the intervertebral disc. In our s'more analogy, the graham crackers are the vertebrae, and the marshmallow is the intervertebral disc. So what I want to talk about next is if there was going to be a herniated disc or a bulging disc, and by the way, they kind of mean the same thing, really, herniating, bulging. If there is going to be a herniated disc, which direction does it go? And the answer is posterolateral. And that's what this arrow is trying to show you. Let me erase it so you can see that black arrow again. By the way, both of these pictures are showing you a herniated disc. And in both cases, they're going in a posterolateral direction. So if there's going to be a herniated disc, which direction is it going to go? Posterolateral. It can't go straight back because straight back is the spinal cord and the spinous process. So it can't go straight back. So it tends to want to go in that direction, but because it can't go straight back, it goes posterolateral. Let's talk about why. Bear with me here. If you think about that s'more analogy, all right? Now, think about it. Do we spend more time in our everyday lives in trunk flexion? Remember, flexion is forward. So if you bend at your waist, that's trunk flexion. If I bend down to pick up a box, bending down, bending at my trunk is flexion. Or do we spend more time in trunk extension? Trunk extension is starting from being straight up and down, going back. It's kind of awkward. Do we spend more time in trunk flexion or trunk extension? Of course, it's trunk flexion. And even if you aren't bending down, if you're sitting, you're still in a flexed position of your trunk. So imagine our s'more analogy. Let's say this is the anterior part of the body, and this would be the posterior. If I'm constantly flexing, wouldn't that put the two front pieces of the graham cracker together? So if you just with your hands fashion them into like one on top of each other like it was a s'more, if I continue to put the front edges, if I put the front edges of the graham cracker together, which way does the marshmallow squeeze? If I continually put the front edges of the graham cracker together, which direction does the marshmallow squeeze? Out the back. So that's kind of what happens in this case. With flexion, over time, the force pushes to the back, and over time, the back part of that annulus fibrosus can weaken and can lead to that disc protruding out posterolateral where it shouldn't be. So you should know this direction, posterolateral, because we do much more flexion of the trunk, squeezes the marshmallow or disc out the back. And you can see what one of the main problems is. When it squeezes out the back, it's going to compress those spinal nerves that leave in the intervertebral foramen, thereby causing symptoms that can go all the way down the back, but back to the leg even. So, lastly, as an aside here, not on the test, a lot of treatment of bulging discs is, physical therapy, but what's the mainstay of physical therapy going to be? Trunk extension. There's a whole series of rehab called Mackenzie extension exercises. And yes, it can get more complicated, but the whole idea is to repetitively do extension. If we got this disc bulging out the back because of too much flexion, well then we just do a lot of extension to push that disc back into its place. All right, good stuff, right? Okay. We're going to remember the ribs. Let's see. I kind of like this picture. It shows you a really good view of the heart and how it's not that far behind your sternum. Isn't that wild? And then look at the aorta. The aorta is the big blood vessel that leaves the heart to send blood out to the body. The aorta is nicely protected between the vertebrae and the heart. I've done the cadaver dissection several times, and the aorta is one of the things that surprised me. It's huge. Reminds me of a garden hose. Okay. Make sure you review the ribs here. 7 pair of true, 3 pair of false, 2 pair of floating. So make sure you review that and how they're different. True means that the cartilage from the ribs connects directly to the sternum. False means that the cartilage has to connect to other cartilage before it attaches to the sternum. So it attaches indirectly to the sternum. And the floating ribs don't attach to the sternum at all. Okay. You don't need to know any of this specifically, but I like this picture because it shows you how the ribs attach to the thoracic vertebrae. So we can see the whole rib, and then here we see the rib in the posterior part fits just like a glove. And there's little ligaments that attach them. Now let me ask you a question. How many thoracic vertebrae are there? Remember we said breakfast, lunch, and dinner? There's 12. How many pairs of ribs are there? Wait for it. 12. So each rib connects to a thoracic vertebra. So I would like you to know that. The ribs posteriorly connect with the thoracic vertebrae. And conveniently, there's 12 thoracic vertebrae and there's 12 ribs. Okay. We're going to go through these pretty quickly. There's not going to be a whole lot that you have to know. Okay, so let's just review. Axial skeleton was skull, rib cage, vertebral column. The function of the axial skeleton is more about protection. That makes sense. The skull protects the brain. The rib cage protects the heart and lungs. The vertebra protect the spinal cord. Whereas the appendicular skeleton is more about movement. Yes, it does give us some support. It holds us up for our legs. But also the appendicular gives us a lot of movement. The appendicular is made up of the arms and the legs. And as I said at the very beginning, also includes your pectoral girdle and pelvic girdle, what attaches the legs and arm to the body. Let's mention that. It's a funny word, isn't it? Girdle. It's kind of like a, updated Spanx. Haha. So the pectoral girdle would be the bones that connect the arms to the body. The pectoral or shoulder girdle would be the bones that connect the arms to the body, attach the arms to the body. Yes, it's made up of the clavicle and the scapula. I just would like you to know the function. The pectoral or shoulder girdle, the bones that attach the arm to the body. It is kind of a weird arrangement. Have you ever thought about, how do we get this arm onto the body, onto the rib cage? The rib cage doesn't have the socket, so that's why, in essence, we have the scapula. It also assists with movement, but all you need to know, pectoral or shoulder girdle, the bones that connect the arms to the body. Okay. So just like I was doing before for the axial skeleton, as I quickly go through the appendicular, I'm just going to point out what you need to know functionally. So what are some of the things that you need to know functionally? Well, for the scapula, the glenoid cavity is the socket. Glenoid cavity is the socket. It's a shallow socket. I talked about this in lab. The glenoid cavity is very shallow, so it's not very strong, but it's what gives us a lot of motion. You only need to know what I am pointing out. Here's an X-ray. Oh no, this head of the humerus should be up here. So it's a dislocated shoulder. In this basketball player, this little divot here shouldn't be there. So she's got a dislocated shoulder. Most commonly, the head of the humerus dislocates anteriorly or inferiorly. But this is all extra. Make sure you pay attention to how the bones connect. So what's going to make up the elbow joint? The elbow joint is made up of the trochlea of the humerus, the trochlea fitting into the trochlear notch of the ulna. The elbow is the humero-ulnar joint between the humerus and the ulna. More specifically, it's the connection between the trochlea of the humerus and the trochlear notch of the ulna. So please pay attention to how the bones fit together to form these joints. The radius does not, look at this picture here, the radius does not touch the humerus. So the radius is not a part of the elbow joint. I do want to point out, however, for the radius, when we rotate our forearm, when you go from your palm up to palm down, that rotation of your forearm is called pronation and supination. What I want you to know is it's the radius moving. When we rotate our forearm, it is the radius moving over the ulna. It's the radius moving. The ulna stays pretty stable, and it's the radius that moves. We already said the ulna, the trochlear notch of the ulna, fits into the trochlea of the humerus to form the elbow. As an aside, you can see there's a interosseous membrane. There's connective tissue that connects these bones, but you don't need to know that. Just make sure you review the groups of bones, carpals, metacarpals, and phalanges. Now, I do want to take a moment, and there's not that much left here, believe it or not. I do want to take a moment to briefly talk about one of the carpal bones. One of the carpal bones is called the scaphoid. You're not going to have to label it, but remember how we said that bones heal well? Yes, we said bones heal very well because they're very vascular. But here's an example of a bone that may not heal well. My cat is joining me here. My apologies. Hi, Oscar. Okay. You want to hear about the little scaphoid bone? I don't know if cats have one. Probably not. So the scaphoid is an example of a bone that does not heal well. So I just want to give this as an example. These pictures are pretty good at illustrating this. A lot of times this fracture could happen if you fall and put your hand out to brace your fall. That mechanism tends to squeeze, compress the scaphoid bone. And what happens is that there's a branch of the radial artery that feeds the scaphoid, that when you fracture the scaphoid, that branch gets severed. And when we sever that tiny little arterial branch, it can lead to poorer healing. So I just wanted to give you an example, and I'd like you to know this. One example of a bone that may not heal well is called the scaphoid because it has a poor blood supply when it fractures in most instances. Lovely MRI here. We can see the outline of the scaphoid, and then there's a crack. The arrow's pointing to the crack. Not so good. So it can heal, it just does so slowly. So they'll be usually in a cast for longer than you usually would. All right, let's round out the end here, coming down the home stretch. Just like we talked about the shoulder or pectoral girdle, there is a pelvic girdle. And guess what? It's the bones that attach the legs to the body. Just like the pectoral girdle was the bones that attach the arms to the body, the pelvic girdle consists of the bones that attach the legs to the body. Now here, it's also about supporting weight, because we're talking about the pelvis. You don't need to know this, but the bones that would make up the pelvic girdle would be the pelvis and the sacrum. That's how we connect the legs to the body. But just know the basic definition. Trying to keep it as simple as I can. So I've got some great pictures that you can use here to review for lab. Some great pictures that show you the 3 regions and etc. What are some things that I want to point out that I could ask you for your lecture exam? Make sure you review the pubic symphysis. The pubic symphysis is a joint that forms between the 2 pubic bones. This is where the pelvic halves come together in the front. There's interestingly a piece of fibrocartilage in between there, and this actually forms a cartilaginous joint, which has a little bit of flexibility for some shock absorption as we walk, but also a little bit of stretch when a woman has a baby. Please review the ischial tuberosity is the protrusion that we sit on. The acetabulum is the socket. Please make sure you review that the acetabulum socket here is deep. So the hip has a deep socket, which is good for support, but less motion. Very straightforward. In general, I would like you to also review some of the basic differences between the male and the female pelvis. Here, we do see some differences, and other bones, not so much. But here we do. Of course, it's all about, for females, being adapted to be able to give birth, yes. If you want to take a guess at the bottom, which is male, which is female, feel free to pause the video. Yes, you got it. The one on the left here is the female. The one on our right is the male. I give you many differences. You do not have to know all of them. Something I want you to know, the female opening is wider. We know why, for the baby. The male opening is more straight up and down, not as wide. I'm just going to point out one other difference. If you look at the curvature of the sacrum and coccyx, if you look at the curvature of the sacrum and coccyx, the male sacrum and coccyx is very much curved. In other words, it kind of curves in, and part of the coccyx is in this opening. Well, not the same for the female. It's less curved. And that, of course, is because we don't want things in that open space. We need that wide opening for the birth canal for the baby to come through. So these adaptations are for childbearing in the female. For males, it's all about strength. So the male characteristics of their pelvis are more about the ability to give strength. There's many more differences, but those are just a couple I wanted to point out that you should review for your next exam. Okay, really down the home stretch here. Make sure you review the hip joint. The hip joint is going to be the head of the femur, fitting into the acetabulum of the pelvis. The knee joint is going to be the medial and lateral condyles of the femur fitting onto the tibia. So just review that, right? The knee joint is the medial and lateral condyles of the femur fitting into the top of the tibia. Let's talk about the tibia. The tibia is the bone that's larger, so because of that, it's more weight-bearing. The tibia has the medial malleolus. Simple, simple. Don't worry about that. The fibula is the smaller bone, not so much weight-bearing. So the function of the fibula is more about acting as an attachment site for ligaments and tendons. And the lateral malleolus is on the fibula. Make sure you review the groups of bones in the foot: tarsals, metatarsals, and phalanges. And then the very last thing from this chapter, I just want to define and give a function, would be the arches. You don't need to know the names of the arches. You don't need to know the names of the arches. But I want to talk about their function. So, as you know, when we look at the bones of the feet, they're arranged in an arch like this. They're arranged to give space underneath. And the reason is because the bones are structured that way so we can fit these connective tissue structures. So the arches are connective tissue bands under the bones of the foot. Connective tissue bands, and they're thick connective tissue. They are thick connective tissue. There are several of them. You don't need to know them, but if you're wondering, you have two that run lengthwise. There's one, here's another. You have two that run lengthwise, and then you have one that runs horizontal in the frontal plane. So you don't need to know that, but I would like you to know the function. So we're going to talk about two functions. One function is shock absorption. Not shack, shock. Shock absorption. Particularly, this shock absorption occurs when you land. Every time you take a step and you land during the landing phase. So we want those arches to be high when you're non-weight bearing, but then when you take a step and all your weight comes down, we want those arches to flatten out as shock absorption. Think about it. If we just had bones like rocks that were just right against the ground, that would not act as very much shock absorption. Your feet are the contact point for all your body weight when you walk. You know, we're bipedal. We only walk on two limbs. So every time we walk and we land, it's a lot of force coming down on relatively small bones. So one of the functions of this arch is that it can stay high when we're not weight bearing, but then every time I land, it flattens out and is a way to have shock absorption. The second function I'd like you to know is it allows for a springing action. And that would occur after landing when we go to push off. The fancy way of saying it is toe off. But after we stretch that arch, then the arch will recoil as we toe off, and that recoiling acts like a rubber band, and it gives us some propulsion. So another way of saying that springing is propulsion. We wouldn't have the ability to push off with as much force as we do without this arrangement. Last thing, because people always ask me, you know, if someone naturally has a higher arch or a fallen arch, you know, you probably know yourself, would you say your arch is kind of flat? Is it higher than normal or is it normal? There are terms for that. You don't need to know this, but someone who has, this is extra. Someone who has flat feet, that's called pes planus. That means that these arches are flatter even if you're non-weight bearing. And then pes cavus would be an abnormally high arch. Pes planus is much more common. People ask me all the time, is this a bad thing? And the answer is, you know, a lot of times the rest of the body compensates. So if you're not having any foot pain or pain associated with your arch, I would say leave it alone. In many instances, someone might have flat feet, but their other parts of their lower body have compensated for it. Because think about it. Every joint in the lower extremity is connected. We call that a kinetic chain. So if someone has flatter feet to begin with, the body early on learns how to compensate. So their ankle, knee, hip, even lower back can adapt a little to account for that. So if there's no pain, even though it might look, oh my God, that's really flat feet. If there's no pain or problems, usually just let it be because probably other parts of the body have adapted. If there's pain or some sort of problem, then it's worth looking into. But, you know, shoving an orthotic or an arch support just because can actually throw things off even more if there's not any pain or problems. All right, so make sure you're focusing on exactly what I've talked about, nothing more, but study hard. I'm here if you have any questions.